Two patients, same hip surgery, same surgeon, same age. One went straight to the operating table. The other spent 8 weeks preparing. The first spent 4 days in the ICU. The second was walking in the park within 3 weeks. The difference was not the scalpel. It was what happened before it. Write this down. My name is James Reyes, and if you watched the last video in this series, you already know that surgical clearance is not the same as surgical readiness. You know that most preoperative visits measure the wrong things, and that nearly 2 in 3 patients walking into elective surgery are not in the category the outcome statistics were built around. Today's video is about what you can actually do about it.
If you have surgery coming up, or if someone you love does, this is the most practical information you will find outside of a clinical consultation. What I'm about to walk you through is not a wellness trend. It is a structured, evidence-based framework that has been studied in thousands of patients and published in peer-reviewed surgical journals. Drop a comment right now with just your age, nothing else. I want to see who's watching this. The term is prehabilitation. Most patients have never heard it, most surgeons do not mention it, and yet it is one of the most researched areas in perioperative medicine right now, and the results are hard to ignore. Here's what prehabilitation is not. It is not rest before surgery. It is not eating better for a week. It is not taking a walk the day before you go in. Those things are fine, but they're not what the research is measuring when it finds the outcomes it finds. Prehabilitation is a structured, multimodal program, typically running 6 to 12 weeks before an elective procedure that targets the body's functional reserve before surgery imposes its biological cost. The goal is simple: arrive at the operating table in a stronger physiological state than the one you're in today. Surgery is a controlled injury. Your body does not experience it as a healing event. It experiences it as a massive biological stressor. Anesthesia suppresses immune function. The incision triggers a systemic inflammatory response. Immobility accelerates muscle loss at a rate older adults can least afford. Blood loss stresses the cardiovascular system, and every one of these demands is absorbed by the same reserve that determines whether you go home in 3 weeks or spend 3 months in a rehabilitation facility. Prehabilitation builds that reserve before surgery depletes it. Nobody told you that was an option. Now here's the number that changes the conversation. A systematic review and meta-analysis published in Clinical Nutrition in January 2024 analyzed 16 studies covering 3,339 patients, all of them frail, older, or high risk, undergoing major abdominal surgery. The researchers looked specifically at what happened when structured prehabilitation was added to the preoperative period. The findings were specific and significant. Patients who completed a structured multimodal prehabilitation program had hospital stays that were on average more than 1 day shorter than patients who did not. Their 6-minute walk test results, a measure of functional capacity, improved by an average of 40 meters before they even entered the operating room. And when the research team looked specifically at severe postoperative complications, the kind classified as grade 3 or higher on the clinical scale used by surgeons worldwide, prehabilitation was associated with a reduction of up to 44%. Up to 44% in frail, older, and high-risk patients undergoing major abdominal surgery. That's not a marginal benefit. That's a signal large enough that the authors of the review concluded prehabilitation should be encouraged, not offered as an optional extra, but actively encouraged in frail, older, and high-risk adults before major abdominal surgery. Most patients never hear this conversation. The surgical team schedules the procedure, the patient prepares emotionally, the body is left out of the planning entirely. This is education, not medical advice. Everything in this video is designed to help you ask better questions and bring a more informed conversation to your own care team. Prehabilitation works across a wide range of surgical specialties, but not all of them equally, and the evidence is specific enough that it's worth knowing where the research is strongest before you bring this conversation to your surgeon. The clearest evidence comes from two categories. The first is major abdominal surgery, colorectal procedures, liver and pancreatic operations, major cancer resections. These are the procedures studied in Clinical Nutrition meta-analysis from 2024.
High-risk, high-stress operations where the body's reserve is the primary determinant of recovery. The 44% reduction in severe complications came from exactly this category. The second is orthopedic surgery, total knee replacement, total hip replacement, lumbar spine procedures. A systematic review published in JAMA Network Open in April 2023 analyzed 48 randomized controlled trials involving 3,570 patients with a mean age of 64 years. Prehabilitation improved function and muscle strength before surgery, reduced preoperative back pain in patients awaiting lumbar procedures with high certainty of evidence, and improved postoperative function in the short to medium term. The research team concluded that a minimum of 4 to 6 weeks with at least 2 sessions per week may be recommended for patients undergoing orthopedic surgery. Cardiac surgery, thoracic surgery, and urological procedures also have growing bodies of evidence. The American College of Surgeons has formalized this through the Strong for Surgery program, a national initiative that screens patients before elective procedures and connects them to prehabilitation resources across nutrition, exercise, smoking cessation, and mental health. Write this down. If your surgery falls into any of these categories, and most elective procedures do, the conversation about prehabilitation belongs in your preoperative planning, not as an afterthought, before the date is set. Now, I want to walk you through what prehabilitation actually contains. Most programs are multimodal, meaning they address more than one factor simultaneously. The research consistently shows that multimodal approaches outperform single-component interventions. Exercise alone produces results, nutrition alone produces results. Combined, they produce something closer to what the body actually needs to handle the biological stress of surgery. The 4 pillars are these. Aerobic exercise. The goal is cardiovascular conditioning, raising the body's oxygen processing capacity before the surgical demand depletes it. Most protocols target sessions 3 times per week at 60 to 70% of maximum heart rate. That is a moderate intensity, elevated breathing, conversation still possible, sustained effort for 20 to 30 minutes per session. Walking counts, stationary cycling counts, swimming counts. The specific activity matters less than the consistency and the intensity target. The goal is not fitness for its own sake. The goal is arriving at the operating table with a cardiovascular system that has more capacity than surgery will immediately consume. Resistance training. Surgery accelerates muscle loss. Immobility accelerates it further. Resistance training before surgery builds the lean mass buffer that protects against that loss during recovery. 2 sessions targeting the major muscle groups, legs, core, upper body, at a level that produces mild fatigue by the final repetitions. Body weight exercises, resistance bands, light weights. The modality matters less than the progressive challenge. In colorectal cancer patients, resistance training improved muscle strength by 25% and functional walking capacity in pre-surgical trials. Nutritional optimization. Surgery is a catabolic event. The body breaks down tissue to fuel its healing response. Protein is the primary substrate for that rebuilding, and most older adults arrive at surgery consuming significantly less than what recovery demands. The protocol parameters that appear most consistently in the research are 1.2 to 1.5 grams of protein per kilogram of body weight per day. For a 70-kilogram person, that is 84 to 105 grams of protein daily, substantially more than a typical diet provides without deliberate attention.
This is not about a special diet or expensive supplements. It is about making sure the body has the raw material to rebuild tissue after surgery depletes it. Metabolic optimization. The fourth pillar addresses modifiable risk factors that directly affect surgical outcomes: blood glucose control, smoking cessation, alcohol reduction, and in some cases, iron deficiency correction. These are factors that the preoperative window can meaningfully address if the conversation happens early enough. A patient who stops smoking 6 to 8 weeks before surgery measurably reduces pulmonary complication risk. A patient whose blood glucose is better controlled before an elective procedure has a measurably lower infection risk after it. Nobody is telling most patients this in the standard preoperative visit. The question I hear most often at this point is, what if I only have 4 weeks? 4 weeks is enough to produce measurable physiological change, not ideal, but meaningful. 8 weeks produces more. 12 weeks for patients who are significantly deconditioned produces the most.
The research from orthopedic surgery specifically recommended a minimum of 4 to 6 weeks with at least 2 sessions per week as the threshold for meaningful outcomes. The window is not a rigid deadline, it is a signal. If your surgical date is already set and you have 6 weeks, that window is not wasted time. That window is the preparation your surgical team has not told you to use. The first 72 hours after major surgery are when the reserve account gets drawn down, and for patients who arrive depleted, it overdrafts. Anesthesia suppresses the immune system for up to 24 hours. The incision triggers a systemic inflammatory cascade that peaks in the first 2 days. Immobility begins immediately, and for older adults, every day of bed rest after 60 can cost up to 1% of muscle mass. Pain management, necessary as it is, further limits movement. The gut slows, appetite disappears. The body redirects every available resource toward the wound. For a patient who arrived at surgery deconditioned, low grip strength, slow walking speed, poor protein intake, cardiovascular capacity already near the floor, the withdrawal exceeds the balance. The body cannot absorb the stress and begin rebuilding at the same time. That is when complications emerge. That is when the ICU admission happens. That is when the discharge goes to a skilled nursing facility instead of home. For a patient who spent 8 weeks building that reserve before the operation, more muscle, better cardiovascular capacity, adequate protein stores, optimized metabolic markers, the same surgical stress lands on a body with more to give. The recovery curve is not the same curve. This is not a metaphor, it is physiology. Write this down. The body does not distinguish between the stress of surgery and the stress of any other major physiological insult. What it has available when that insult arrives determines what happens next. Prehabilitation is the only intervention that expands what is available before the insult occurs. Rehabilitation, physical therapy after surgery, is valuable. Nobody disputes that. But there is a fundamental asymmetry between building reserve before surgery and trying to recover it afterward. The body after surgery is already in a catabolic, depleted, inflamed state. That is not the optimal environment for building capacity. The optimal environment is the 6 to 12 weeks before the procedure, when the body is intact, motivated, and responding to training signals normally. A recommendation is not a verdict. A surgical date is not a starting line, it is a deadline. The starting line was the moment your surgeon said you need this procedure. Now here's what the research cannot tell you, and this matters for compliance. Prehabilitation programs vary enormously. Duration varies, intensity varies, whether they include supervised sessions or are entirely home-based varies. The evidence supports both supervised and unsupervised formats, with adherence rates above 70% in 19 of 21 trials that tracked it, which suggests that patients who are motivated to prepare actually follow through at high rates.
But the critical variable is not the program, it is the conversation. Most patients who would benefit from prehabilitation never start it because no one tells them it exists. Most surgeons who know it exists do not have the infrastructure or the appointment time to implement it. The American College of Surgeons' Strong for Surgery program was designed specifically to close this gap, providing a standardized screening framework and connecting patients to prehabilitation resources before elective procedures. It is available, it is evidence-based, and it is underused. Nobody is failing here through malice. The system was built around a different model of surgical preparation, one in which the surgeon optimizes the procedure and the patient passively receives it. Prehabilitation requires a different model, one in which the patient is an active participant in their own surgical outcome, starting weeks before anyone touches them. You are not a passive recipient of medical decisions. You are an informed participant in your own health. And that means you can walk into your surgeon's office before your procedure date with a specific, informed question, not a vague request, not a complaint, but a clinical ask that signals you have done your homework. Here are 3 steps, each one concrete, each one actionable before any elective procedure. Step 1. Name it.
Ask your surgeon directly. I have read about prehabilitation programs before major surgery. Is there one I should be following before this procedure? That one sentence does 3 things. It tells your surgeon you are an informed patient. It opens the door to a conversation that most surgical teams do not initiate, and it immediately reveals whether your care team has a protocol or a referral pathway for prehabilitation, because either they do or they do not, and the answer tells you something important. If they do, ask what the program includes, how long it runs, and whether it involves a physiotherapist and a dietitian. Those are the 2 specialists who appear most consistently in effective prehabilitation programs. If they do not, ask whether a referral to a physiotherapist for preoperative exercise planning is appropriate. That is a reasonable clinical request that any surgeon can accommodate, and it gets you the individualized assessment the research consistently shows matters for exercise safety and dosing. Step 2. Start the nutrition conversation now. You do not need a prescription to increase your protein intake. You need the number. For most adults over 60, the target that appears most consistently in prehabilitation research is 1.2 to 1.5 grams of protein per kilogram of body weight per day. For a 70-kilogram person, that's 84 to 105 grams per day. For an 80-kilogram person, that's 96 to 120 grams. Distribute it across meals. 20 to 30 grams per meal 3 to 4 times a day is more effective for muscle protein synthesis than concentrating it in one sitting. Eggs, fish, chicken, legumes, Greek yogurt, whole food sources first, supplementation if needed to hit the target consistently. This is not a diet, this is surgical preparation, and it can begin today. Step 3. Use the window. If your surgery is scheduled 6 or more weeks out, that's your window. Start moving now, at whatever level your body currently tolerates, and progress deliberately. 3 sessions of aerobic activity per week at moderate intensity, 2 sessions of resistance training targeting the major muscle groups. Both are well within reach for most patients awaiting elective procedures, provided individual assessment confirms safety. If your surgery is 4 weeks out, start anyway. The research shows meaningful physiological adaptation is possible in 4 weeks. It's not the ideal window, but it's not an empty one either. If your surgery is 2 weeks out, focus on the nutrition. Protein optimization and metabolic preparation can still shift the recovery curve even in a compressed timeline. The window is always worth using. Let's recap what this video covered. Prehabilitation is a structured, multimodal preoperative program, typically 6 to 12 weeks, that builds physiological reserve before surgery depletes it. A 2024 meta-analysis in clinical nutrition found it reduced severe complications by up to 44% in frail and high-risk patients undergoing major abdominal surgery.
A 2023 JAMA Network Open review of 48 trials in 3,570 orthopedic patients found it improved function, strength, and quality of life before surgery, and function in the short to medium term after it. The 4 pillars are aerobic exercise, resistance training, protein optimization, and metabolic preparation. The minimum effective window is 4 to 6 weeks. The ideal window is 8 to 12. The starting line is the moment surgery is recommended, not the day before you go in. The surgery is the event, the recovery is the real test, and prehabilitation is the training. Drop "informed" in the comments if this video changed what you are going to do before your next procedure, and share this with anyone who has a surgery coming up, because this is the conversation their preoperative visit probably did not have. Next video, your surgeon recommended an operation, but surgical recommendations are not always straightforward, and there are specific questions every patient should ask before agreeing. That's coming up next. This video is for educational purposes only and does not constitute medical advice. Prehabilitation programs should be developed with the guidance of qualified healthcare providers, including physiotherapists, dietitians, and your surgical team. Always consult your care team before beginning any new exercise or nutritional program before surgery.